So, good evening, everybody. Myself, Dr. Manish Kumar Jain. I am consultant nephrologist and transplant physician in Apollo Multi Specialty Hospital, Kolkata. Today, I will discuss about the pedal edema. As we know, pedal edema is a very common complaint of the lot of the patients, and today it is a very indicator of the chronic kidney disease. I will discuss what is pedal edema and how it signifies the chronic kidney disease. Pedal edema basically characterized by the accumulation of the fluid at the ankle and the feet. And you can see easily by compressing it. If it is compressed, it suggests that it is a pedal edema. Now, someone will ask why the pedal edema is common. Because it is dependent on the gravity. Because everything is going down. So when you are standing position, the water will go down and get accumulated around the feet and the ankle. Because of that, it is generally we see patient with renal disease with pedal edema. Now, how the pedal edema develops? As we know, generally the fluid remain in the vascular compartment, means in our blood vessels, including large artery, small artery, and the teeny arteries. The blood protein, the oncotic pressure produced by them, play important role to maintain the fluid in the blood compartment. But there may be some leak of the fluid may be there, and that generally get absorbed and go back to the vascular system through the lymphatic system. But in many conditions where either the intracapillary pressure increased or either this protein mediated oncotic pressure decreased, then fluid come out from these vessels, especially capillaries and arterioles, better to say mini blood vessels, and get accumulated around the tissue or themselves. And when this fluid accumulation is greater than the capacity of our lymphatic system, then you can see it easily. Okay. Now, why the patient with kidney disease develop the pedal edema? In chronic kidney disease, there may be the function of kidney decreased, means the glomerular filtration is decreased. Because of that, kidney unable to excrete or remove the waste product as well as the fluids from the body. Because of that is get accumulated, or in many condition, like in nephrotic syndrome, when the proteinuria is there, means the protein is leak from the kidney, from the blood in the urine. In that condition, the fluid, there will be hypoproteinemia, and that will cause the accumulation of the fluid in the body, in the ankle. When you are keeping yourself lying down position, like we see in the old age patient or sick patient, then you will see fluid in the sacral area. That is called as a sacral edema. And in the patient with chronic kidney disease, when this fluid accumulation takes place, in an advanced stage, it may get accumulated in the abdomen as well as our pleural cavity, means the area around the lungs. And it become advanced, the patient will develop severe respiratory distress, orthopnea, and PND. This accumulation of fluid maybe takes place in other conditions also, like heart disease and in the liver disease. Sometimes we see this pedal edema also in the patient with the loss of the protein in the intestinal system. That is, we call as the protein lacing enteropathy. When a patient with pedal edema comes to a physician, we take proper history and physical examination, and subsequently we go for some blood and imaging studies, blood test. The history is very important because the history gives you a clue from where the pedal edema develop. Because the pedal edema may develop because of heart disease, because of liver disease, and protein losing enteropathy. So suppose a patient giving history that in the early morning his face becomes swollen. In that condition, the it suggests that the patient have pedal edema because of the kidney disease. In some time, the patient gives history that first his abdomen gets distended and then pedal edema develop. They suggest there may be liver disease there. Sometimes patient give history that they develop orthopnea, PND means dyspnea on exertion, when problem with respiratory strain on lying down position and the respiratory strain nighttime position. In that subject may be cardiac disease. So this history give you from where the edema may develop. Then we go for physical examination. We see the which part of the where the edema get extended in the pedal on lower limbs only, on the upper limb, in the abdomen, in the lung by auscultation, by physical examination of the patient. That also give you some clue. And So then after we proceed for the some blood and the urine examination, some imaging studies to find out what is the why does this pedal edema develop. Routine tests are urine routine. They suggest protein. If the protein is present, in urine, it suggests that the protein is losing out from the kidney. Then sometime we do blood examination of the serum creatinine. Creatinine is high. They suggest that there is kidney problem is there in the patient. After that, we go for the some imaging studies, including the ultrasonography of the abdomen. Very, very important test in the nephrology. By ultrasonography, we see the accumulation fluid in the abdomen. Along with that, we can see what is the stress of kidney, if the kidney is small or is large, or there may be stone that cause obstruction in the kidney, or there is a bilateral kidney and ureter are got distended, that's a obstructive disease, or there is a cortex with or the outer portion of the kidney that is damage, then such as the chronic kidney disease. So by ultrasonography, we get a lot of the information to suggest is acute kidney injury or is the liver disease or it is the renal disease itself, that is a chronic kidney disease. And then subsequently we go for some further investigation, including the CT scan of the abdomen that gave you a clue if the obstructive system is there or not, like because of the stone or tumor. After that, we can go for the radionuclide study that give you functional and the structural information of the kidney. Chronic kidney disease characterized by the decrease in the renal function. They last for more than 3 months. That may be in the form of the proteinuria or decrease the GFR, or there is the obstruction in the kidney more than 3 months. Then it is called as the chronic kidney disease. After that, we try to find, after investigation, we try to find out other complication because of the renal disease, including the anemia, any bone disease, or any cardiovascular complications, or any other problems. After that, we advise some management of the pedal edema. The management of the pedal edema consists of water restriction. That is a very important part because a lot of the patient, they take a lot of water, they in the mind that when there's lot of water, they will take lot of water, there will be more urine, but it's the fallacy. Because when you take more water, there may be some in kidney output, but the extra water get accumulated and there may be more pressure in the kidney. So we restrict the water, we restrict the salt, and we also ask the patient to measure their output, what is the output, and according to we decide what could be the intake. Generally, we say that what is the output, you take input according to that. After that, we also give some medication like diuretics, like common language Lasix. So remove this extra water from the body. After that, we give some medication according to what is the possible etiology of that disease, including the hypertension, maybe sugar for control of that. And in the subsequently, we are some lifestyle modification, including the dieting modification, the CKD patient, including the low protein diet. We advise to avoid the alcohol, smoking, and also advise to pay some exercise so that the patient can feel weak, okay, better. There should be sense of well-being and the proper control of blood pressure, sugar after proper physiotherapy or exercise. So, ladies and gentlemen, I try to explain what is the pedal edema and how we can manage it. Thank you very much, and I think you will get benefited from this video. Thank you.